Okay, hypertension and heart. It is actually, I'm gonna cast light with you and through our discussion together about the effects of hypertension on the heart and how these effects can be so devastating. And just we are gonna have a little bit of unorthodox approach to hypertension, because we know hypertension causes LVH, predisposes to atherosclerosis, but does it lead to more than that? We are gonna find out. Now, before that, before we dive in, I'm gonna just walk you quickly through some questions, and I am hopeful that you are gonna interact with me about these in these questions. So first, I want one of you to explain the statement that hypertension is a triple paradox. What does that mean? A triple paradox. If you have ever come across that statement before, or if you have any guess about what does it mean, triple paradox. So triple paradox means there are three paradoxical features in hypertension. Paradoxical means something that is hard to assimilate, ironic, contradicting, stuff like that. So the triple paradox means that, I mean, hypertension is referred to as a triple paradox because it is easy to diagnose, right?
Yes.
All you need is a stethoscope on a cuff and you know, a sphygmomanometer. But most of the time, it's undiagnosed or erroneously diagnosed. This is one of the paradox. Two, easy to treat. It's just about medication. But most of the time, it is untreated or undertreated. Number three, there are so many medications, okay, for hypertension, like in the vast majority of hypertensive patients are not reaching the targets. So that's why it's triple paradox. Easy to diagnose but not diagnosed, easy to treat but untreated, many drugs but not optimal treatment of hypertension. So you know that this is the triple paradox of hypertension. Now, what about, or what do you know about interventional therapy for hypertension? Do we ever have any interventional therapy for hypertension? Interventional therapy.
I think yes.
Which is what?
I didn't remember it, but it's related to the nervous system.
Oh yes, good, Dr. Suhair. Yes, I think you are probably alluding to renal denervation, okay, which is denervating the sympathetic system, innervating the renal artery, and by doing so, we expect that the blood pressure is going to be better controlled. So yes, so does this procedure work, renal denervation? We are going to find out just a moment. Okay, and now, what do you know about why it's called hypertension?
The blood pressure office, but in the 24-hour blood pressure monitoring.
Sorry, again?
Normal blood pressure in the office when in hospital. High in the 24-hour blood pressure monitor.
Probably you mean the opposite, Dr. Suhair. This is white coat hypertension.
White coat high in the office and normal in the
yes,
for
very
our
good. So white coat hypertension is high in the white coat hypertension and mask hypertension are both sort of non-concordance between office and home blood pressure monitor. So the office blood pressure measurement in white coat hypertension are higher than at home. And in mask hypertension, exactly the opposite is taking place. In mask hypertension, the office blood pressure is normal, but the ambulatory and home measurements are high. Okay? So what is resistant hypertension?
the hypertension on 3 antihypertensive maximum dose including diuretics.
Exactly. So when hypertension fails to come to the targets after 3 months at least with 3 medication, including diuretics. Okay. So this is resistant hypertension. Okay. What are the prerequisites for proper blood pressure measurement? Let's discuss this one in depth. So if you have your patient comes to you in the clinic, so how are you gonna measure the blood pressure? Anything about positioning patient, his hand, cough, stethoscope, how you are gonna measure it, and let me know about that. Let's take your opinion about our ways of properly optimizing the blood pressure measurement. Okay.
Sleep 8 hours at least at night and calm and in the morning and in sitting position at the level of the sphygmo should be at the level of the patient and in the morning with well-fitted good size cuff.
Okay, good. So you mentioned 2 important factors: the proper sizing of the cuff and sitting position. Yes, so comfortably sitting in chair, okay, with his back leaning backward on the chair, so he shouldn't be leaning forward. His feet, shall his feet be above the ground, at the floor, or on the floor?
On the floor.
It must be on the floor. It must be on the floor. His hand, shall it be above, below, or at the level of the heart?
At the level.
At the level of the heart. And when he comes to your clinic, are you gonna just wrap the cuff immediately and measure it, or you're gonna wait for some time?
No, I wait to the patient to be calm.
Yes, exactly. Okay. And are you gonna converse with the patient while you are measuring the blood pressure? Are you gonna talk with the patient?
No.
No. Good. Okay, so these are all important requirements for proper check of blood pressure. Now, what is nocturnal dipping of blood pressure, and how it is, or how is it clinically meaningful? Do you know the nocturnal dipping of blood pressure? Nocturnal dipping.
10 millimercury of the daily blood pressure.
So
it's less than 120 over 80.
So you mean nocturnal dipping is 10?
10 millimercury below the daily control blood pressure.
At night?
Yes, during
Okay.
night.
Yeah, so the blood pressure is not uniform over 24 hours. So we're going to see that shortly. At night, it goes down, and during sleep, it goes down, and there is a morning set. This is physiological pattern, okay? But it is important to have nocturnal dipping. The absence of nocturnal dipping is associated with higher mortality. لاحظوا هنا النقطة الثانية. If you are hypertensive or you are not hypertensive, the absence of nocturnal dipping is a prognostic feature, with or without hypertension. Of course, the picture is more compounded if the patient is already hypertensive. Okay. Now, does ambulatory blood pressure monitor add any value above and beyond the conventional blood pressure measurement?
Yes.
Uh-huh.
In case of mask hypertension.
Uh-huh. Mask hypertension, white coat hypertension. Uh-huh. What else?
And sustained hypertension.
Sustained hypertension. Mm-hmm.
In pheochromocytoma, when the blood pressure become hyper in paroxysmal rhythm,
Okay.
undetected
Yes.
most of the time.
Exactly. This is good. So the paroxysmal pattern of hypertension, like in pheochromocytoma, which otherwise you wouldn't or you cannot detect it by a single snapshot at office because his blood pressure is kind of paroxysmal. Okay, good. What else?
In patient with evidence of end organ damage without high blood pressure.
Okay, so yeah, so patients whom you are suspect that they are hypertensive, but their office blood pressure isn't high or it's normal. So you want to see how the blood pressure is behaving over a longer period of time. Okay. Mm-hmm.
Can
Anything
it
else?
be used for treatment to assess the response to
Yes.
treatment?
Very good. How? How?
If
It
you
is
give the
important.
treatment,
Huh.
yes, you start the treatment, then you put the ambulatory blood pressure and
Okay.
see the reading if the patient responding to treatment, need other drug, or you need to increase the dose.
Yes, exactly. So it can test the efficacy, the antihypertensive. Okay, or in how much they drop, yeah, and how much this efficacy is sustained over 24 hours. This is also important. You know, the problem is when a patient comes to you in the office, he comes day or night, you have a snapshot of his blood pressure. And you assume this snapshot is representative of his 24-hour blood pressure in the entire, day, which is not right. Okay. Sometimes we have seen so many patients whose blood pressure is normal or in the target at some times, but it goes high at other times. And some patients, their blood pressure, because they are taking morning dose, morning tablets, so their blood pressure until the evening time, 6, 7, it's fine. After that, it goes high. So in this case, I have to readjust the dosing or add a night dose or add a night tablets. Okay.
Yeah. Okay.
So we are going to judge about how optimal the blood pressure is controlled and how sustainable the blood pressure control is. Okay.
Okay.
How does hypertension lead to or aggravate mitral regurgitation? First of all, does hypertension have any association with mitral regurgitation?
Yes.
Tell me.
Increase the grade of severity mitral.
Sorry?
Increase the grade of severity of mitral regurgitation. Increase in the assessment severity of mitral regurgitation.
Sorry, the
At
sound
the
comes cracky a little bit. Oh, sorry?
okay. When assessing mitral regurgitation with high blood pressure, there is a tendency to increase in the severity grade
Very good. Very good. You are so right. That
because
is,
it's affecting the preload.
thank you, Rabah. Thank you so much. This is exactly right. Well, yes, yes. So the mitral regurgitation is dynamic, because it depends on loading condition, preload and afterload. So like, you know, we have seen that during pregnancy, for example, the mitral regurgitation tends to be overestimated because of volume expansion. If the patient had fluid deficit or he has been on the aggressive diuresis for some time, the severe mitral regurgitation might now look lesser. Okay, that's because of preload changes. We also know that mitral regurgitation is affected by afterload. You know, sorry, if you can mute yourself. So if there is a high blood pressure, that's gonna back down, you know. So more of MR is gonna appear. And if the patient goes hypotensive, less of mitral regurgitation is gonna appear. That is dynamic, the dynamic picture or the dynamic behavior of mitral regurgitation. Okay. But I'm gonna show you another important association that tends to be kind of causal. There is causality between hypertension and mitral regurgitation. I'm going to show you that shortly. How does hypertension affect the progression of aortic stenosis?
Due to increase the afterload.
Okay.
When it increases the afterload, it increases the gradient.
Increase the gradient. Afterload, increasing the gradient. Okay.
Hypertension increase atherosclerosis.
Okay.
Yeah.
Okay, so you are right. So because you know aortic stenosis, the senile sort of aortic stenosis in particular, shares the same mechanism of atherosclerosis. So whatever predisposes to atherosclerosis probably predisposes to aortic stenosis, and hypertension is one of the risk factors of atherosclerosis. This is one speculation. Another one is hypertension. When you have hypertension and aortic stenosis, how is that gonna change the comorbidity? Like if the patient is having normal blood pressure with the same severity of aortic stenosis, are these two patients different? A patient with high blood pressure and severe aortic stenosis, a patient with normal blood pressure and severe aortic stenosis.
If I control the blood pressure, the gradient will be less. So that's normal. If I control the blood pressure,
sound is not clear.
The sound, yeah, the sound is coming. So I think yes, crack, yeah. Try again. Anybody? Do you hear my sound or I'm lost?
Yes.
Okay. So we are still discussing how hypertension affects the progression of aortic stenosis. We said that it's a risk factor of atherosclerosis, and aortic stenosis in some ways is like atherosclerosis. What else? Okay, so we're gonna find out shortly. Now, you can mute. Okay. So now we have spoken about the interventional therapy of hypertension. Interventional therapy of hypertension, there are two. The angioplasty or PCI to renal artery stenosis. This is one type of intervention. And renal denervation, a second type of intervention. Renal artery stenosis is found to be associated with elevation of or activation of RAS system and hypertension. So if a patient is having significant renal artery stenosis with resistant hypertension, shall I go ahead and try to fix it interventionally or just the recourse to medical therapy? What do you think? Renal artery. Rabah, I think the sound that comes from your mobile is a bit cracky. Anybody can answer?
If fixed, the hypertension will improve.
Okay. Okay. But in fact, landmark trials in renal artery stenosis, including the STAR, the Dutch RAS, the Astral, the Coral, okay, all failed to find any significant benefit over medical therapy for PCI of renal artery. Okay, so intervention doesn't work here, doesn't work. And there is a multitude of studies that have all confirmed that medical therapy is equivalent to stenting intervention. And in fact, in some trials, there is a tendency towards harm by PCI. Yani it's better, medical therapy is probably better and safer. Okay, this is one thing. Now, what about renal artery stenosis? I mean, what about renal denervation? Renal denervation. You know, renal denervation is basically about radio frequency ablation of the sympathetic pluxes around the renal artery. So you are doing sort of sympathectomy, okay? And by so doing, you are lowering the blood pressure by blunting the sympathetic activation, which leads to RAS activation. So theoretically, it's appealing, but unfortunately, the Simplicity trial, which is Simplicity 3, has shown that the denervation is on one side and the sham on the other side, and no difference in blood pressure control between the sham and denervation. What do we mean by sham? What do we mean by sham? This word, you will find it a lot in clinical trials. Sham, sham, sham. Sham. Anybody? Anybody can check his dictionary. شام يعني وهمية كده، عارف؟ يعني مثلا these patients are divided into two arms, denervation arm and sham arm. So معناته ايش؟ كل الناس جابوهم with a high blood pressure on the same antihypertensive, then they divide them into two groups. Groups هيمشوا ل actual denervation جروب هيمشوا لشام، بمعنى الاثنين هيمشوا للكاث لاب، الاثنين هيعملوا angiography. اوكي، one of them هيعمل denervation والثاني ما هيعملوا له denervation، لكن both are blinded about what is done to them. الشام معناته no actual denervation is done، ولكن angiography was done. The patient was taken to cath lab, angiography was done, but no denervation was done. Like in denervation, actual denervation was done. So they have found that those who have denervation and those who have sham, their blood pressure is as equal in 6 months down the line. Okay, that means denervation is no better than sham. Okay, We have done few hundred cases of renal denervation, and we were so optimistic that renal denervation is going to add to the armamentarium of hypertension management, especially in resistant hypertension. But unfortunately, after Simplicity 3, we stopped doing it. لكن الآن في بعض الناس they are trying to revive this therapy again, and they assume that the failure is not due to the failure of the concept and the theory, but of the technique. You know, that's we go through the renal artery and we denervate by radio frequency ablation. So if we optimize the technique, we might get a benefit. Okay, so time is gonna tell. Okay, now I'm gonna ask you a question. If you have a hypertensive patient comes to your office, he is on monotherapy and his blood pressure above the target, so you wanna do some action. Will this action be up titration of this monotherapy, or switching to another monotherapy, or adding on another medication? So we have three responses here, right? Three responses. Either you up titrate. So if you can mute, yeah. Okay. So the three responses are, sorry. The three responses are either you up titrate the monotherapy. Yani patient, if the patient is on amlodipine 5, you might opt to increase his amlodipine to 10. That's one response. Now, a second response is, okay, keep him on amlodipine 5, and I'm going to add prindopril 5. Second response. Or you know what? Amlodipine 5 is not working anymore. I'm going to just throw it out the window. I'm going to start the patient on hydrolysine, for example, or let's say valsartan. Okay, which response you usually take here?
I prefer to add another drug.
Adding another drug. Okay. But remember, adding another drug is going to threaten the adherence. So are you going to do that?
Fixed combination.
Fixed combination. That's a good idea, yes? Fixed combination.
Combination therapy in one pill.
Okay, combination therapy in one pill. But if you don't have, let's say you don't have this fixed combination, you have just separate pills. Are you gonna just keep up titrating, or you still insist on adding another therapy?
Better to add on.
It's definitely way better to add than up titrate the monotherapy. And of course, switching from monotherapy to monotherapy is bad policy. Don't ever dare to do it. Unless the patient is having side effects from medication, stuff like that, yes, you may. But otherwise, for failure of control, don't switch from monotherapy to monotherapy. The best policy is to add on. Okay. Now, are we talking evidence or just speculation? We are definitely talking evidence. If you look here at this slide, you can see how much adding on and doubling the dose are different in terms of efficacy. The efficacy is way better if you add than if you up titrate a monotherapy. Okay. Does that make any sense to you? Yes, it does. لسببين. أولا غالبا الميديكيشن دي عندها أو tolerance after which it's not so efficacious. يعني like you remember the statin, you know, the initial up to 20, the efficacy is much more than doubling after that. You know, it's the same here. So Amlor 5. And then when you double, you don't expect the double response here. Never expect double response here, okay? This is one thing. It's not as efficacious. Besides, it's gonna bring about intense side effects. While if you use multiple antihypertensive, they are gonna act synergistically, and you might, you might end up giving moderate or low doses of each one, and that's gonna alleviate the side effect on one side and enhance the efficacy on the other side. Enhances the efficacy. Why do we enhance the efficacy? Because if you look at the pathogenesis of hypertension, it is multi-mechanistic. There are multiple mechanisms in place, operating together synergistically to produce this hypertension. So it's better to attack hypertension at different levels. If you attack at one pathway, a compensatory mechanism is going to arise in the other pathways. Okay, that's why now people are advocating multiple therapy in hypertension, sometime right from the start. Okay, good.
Yes.
Now, what about how intensive shall I go? How intensive shall I go? Do you believe that we should lower blood pressure below 120/80 or below 140/80, for example? Systolic below 140, or you prefer it to be below 120?
Below 140.
Below 140. Okay.
Based on sprint trial.
Sprint trial, what did it find?
In intensive group,
Okay.
it improves the non-fatal MI by 1.7. And in the other group, the mean blood pressure 136 by 2.2, the primary outcome.
Yani the primary outcome was better in which group, the intensive or the standard?
In the standard.
Really?
The intensive.
In the intensive. The one sprint is a recent study, 2017. So if you look here, what their aim was to compare standard versus intensive treatment. The definition of a standard is lowering blood pressure lower than 140. A target is lower than 140. Intensive group, a target is lower than 120, and they compared these, and they actually terminated the study prematurely because of clear evidence of benefit in the intensive treatment arm. Okay, in terms of cardiovascular events and mortality, and in terms of mortality for all causes. 25% and 27% benefit for the intensive group versus the standard treatment group. That means now we have evidence that lowering blood pressure below 120, you are gonna reap a robust cardiovascular benefit lower than 120. Lower than 120. Okay. Now the same study has probed into, okay, here it's not about, I'm gonna just get better outcome. It's about how much the patient can tolerate this intensive therapy and adhere to this intensive therapy and won't have side effects. And actually, this study actually had shed light that the tolerability of intensive therapy and the adherence to intensive therapy is not bad at all. It's as good as in the standard treatment. So we have evidence that intensive therapy is well tolerated and well adhered to, but way more efficacious than standard treatment. So the target might move to less than 120. Okay. Good. But have you ever come across this terminology? I'm going to show you here. Clinical. It's very difficult to write in this dot. Clinical inertia. inertia. E, this is E, I'm sorry for the bad writing. R, T, I, A. Clinical inertia. Anybody has any idea?
Yeah, it is under treatment of the patient.
Mm-hmm. Yes. Under treatment, the physician or the health provider is not taking the necessary step to escalate, intensify therapy to reach the target. Somehow في خمول إكلينيكي. الخمول الإكلينيكي. ما ليه؟ يعني غالب it's not lack of knowledge, by the way. Physicians know so well about guidelines, recommendation. They know that intensive therapy is probably better than standard therapy. They know this patient blood pressure needs more of escalation of medical therapy, like they don't do that. This is called clinical inertia. And there are so many, factors underpinning this phenomena, which is really, I think it is deeply rooted in medicine. And we might have a separate presentation about it in the near future. But it's a big problem, actually. Now, we know that hypertension leads to LVH, which is left ventricular hypertrophy, ischemic heart disease, and heart failure with preserved ejection fraction. I wish you pay me your attention in the next few slides because it's important, a bit complex. So, does hypertension lead to pulmonary hypertension? I just need yes or no. Does hypertension lead to pulmonary hypertension?
Yes.
Yes?
Yes.
Is hypertension a cause of mitral regurgitation?
Yes.
Can
Yes.
hypertension be arrhythmogenic?
Yes.
Yes.
Can hypertension lead to heart failure with ejection fraction?
Yes. At the end stage.
Is hypertension a cause of atrial remodeling and atrial fibrillation?
Yes.
Can hypertension contribute to the progression and severity of stenosis?
Progression and severity. Yes.
Okay. Does hypertension affect the aortic root function and size?
Yes.
So the answer is yes to all these questions. We said that the stages of hypertension, I mean, there are different phenotypes, white coat, mask resistant, malignant, hypertensive emergency, and hypertensive urgency. Urgency meaning having blood pressure that is really high, above 180 over 120. If it's associated with end organ damage, then this is hypertensive emergency. A malignant hypertension is also having end organ damage, encephalopathy, retinopathy, and all of that, renal impairment, and all of that. Okay. Mask hypertension, we talked about that. White coat hypertension, we have defined that. Resistant hypertension is failure to control blood pressure after 3 months of 3 antihypertensive, including diuretics. Okay. So now the current landscape of hypertension is a shift from statistical threshold to outcome-driven threshold, meaning إنه يا إخواننا الموضوع is not statistically. بمعنى it's not about normal and abnormal. They have tried different thresholds. Okay, and they found that wherever the outcome start to rise, معناته that's the threshold. يعني الآن مثلا this trial, sprint trial, probably is going to define 120 as a new target لأنه it had shown that lowering the blood pressure below 20 is an outcome associated with better cardiovascular event and better mortality. So we're not talking about statistical, we are talking about outcome-driven threshold. So wherever the outcome takes us, probably is going to set new threshold. ولذلك الثreshold for hypertension has been dynamic and will always be. Okay. So refine the diagnostic by ensuring proper measurement and the use of ambulatory blood pressure monitor. Now the guidelines recommendation are talking over and over again about the proper measurement, stressing and overemphasizing, actually emphasizing on the proper measurement and the use of ambulatory blood pressure monitor if possible. Okay, and the contextualized approach to hypertension بمعنى is not, it's more important to know what type of patient has the disease than what disease the patient has. So it is not about hypertension, it's about what patient is having hypertension. What are the clinical characteristics of this patient? Okay, so that is going to change your mood and mode of management. Okay, a patient of blood pressure 130, let's say, but he had cardiovascular risk factors, vascular disease, peripheral vascular disease, and stuff like, you might start treating. Like in another patient with the same blood pressure, without without established cardiovascular disease, you might not start. So it's about contextualizing hypertension. Now, the measurement of pressure, and we have discussed that. First of all, patient has to come to you, has to rest in the chair for 5 minutes or so until he takes his breath, his sweat dries, and relax a little bit in this weird environment of the clinic. Then no conversation while you are measuring the blood pressure. Ensure that the patient is having empty bladder, because full bladder is gonna elevate the blood pressure. The use of correct cuff size, and there are some guidance about how to choose the right size. And place blood pressure cuff on bare arm, not on the patient clothing. Support arm at heart level. Keep legs uncrossed, never crossed, uncrossed, because that's going to increase the blood pressure. And support back and feet. So the back has to be on the back of the chair, and the feet has to rest comfortably on the floor. Failure to do any of these is gonna give erroneous measurement of the blood pressure. Okay, so these are important recommendations of optimizing the blood pressure measurement. Now, what is the classification of hypertension? According to ACC/AHA guidelines 2017, which is still valid today, we have normal, elevated, stage 1, stage 2. طبعا if you are an old generation like me, يمكن تقولوا إنه زمان كانت في pre-hypertension stage 1, stage 2, and stage 3. Okay. Stage 1 starts from 140. Pre-hypertension is before that. Okay. لكن الآن it has changed. Normal is less than 120. See, it is less, not equal. Less than 120 over less than 180 over less than 80. So less than 120 over 80. Now elevated is between 120 and 129, but the diastolic is less than 80. Stage 1 is between 130 and 139, or now here we shift from and to or 80 to 89. Stage 2 is equals to or more than 140 or more than 90. So if I have this blood pressure, 120 over 89, 85, what is this? What stage is this? 85.
Stage 1.
Stage 1, exactly. Because or, when here, this is or. It's coming here. Okay. If I have a blood pressure which is 132 over 60, what is this?
Stage 1.
Is stage 1. Okay. So remember this one. This elevated, you can call it pre-hypertension, no harm in that. So it's either elevated or pre-hypertension, but remember stage 1 and stage 2. Now for stage 2, unconditionally treated. يعني بمعنى for stage 2, you have to start treatment unconditionally. يعني you don't have to wait for other conditions to be satisfied to treat it. لكن for stage 1 is conditional treatment. بمعنى if and only if there are some other supportive condition حتى تبدأ treatment. يبقى stage 2 is unconditional treatment, stage 1 is conditional treatment. What's the conditional treatment? أولاً, the patient chronic kidney disease, diabetes, heart failure with preserved ejection fraction, urine albumin creatinine ratio is high, known cardiovascular disease, post-renal transplant, peripheral vascular disease, or you use this calculator to calculate the risk. It's more than 10% risk of atherosclerotic cardiovascular disease, which include age, gender, race, cholesterol, systolic blood pressure, diastolic, diabetes, and smoker. This is an important calculator. Okay, so in case of any of these, that's the contextualization of blood pressure. So bringing the blood pressure back into clinical data, what this patient is in terms of factors. So if we find that he is high risk, we are gonna start in stage 1. Start treatment in stage 1. Okay. If not, then we can just recourse to non-pharmacological therapeutic lifestyle changes without medical therapy. I wish so much you get this point, you absorb it. Well, that's fine.
Yes, we are following.
Great. Now, why ambulatory blood pressure monitor? Why? Because it defines why it's called hypertension, right? And sometimes there are so many patients come to you in the clinic, their blood pressure is like 130, sometimes it goes to 120, sometimes 140, sometimes it goes to, it's borderline, it's not high and sustainably high, it goes like that. So we call them borderline hypertension. Ambulatory blood pressure is important. Elderly patient, because their blood pressure takes kind of non-sustainability over 24 hours and might have hypotensive bouts. They might have hypotensive bouts. So elderly patient ambulatory blood pressure will define the hypertension load or the blood pressure load, and if they have hypotension. Identifying nocturnal hypertension, and this is really important. Some patients might have normal blood pressure during the day, but it goes high during the night. You know, you need to know these people. In patients who have resistant hypertension, in patient, and I think you have answered that the efficacy of drug treatment can be tested by ambulatory blood pressure. And importantly, we need to test the efficacy of drug treatment over 24 hours. I have seen a couple of patients whose blood pressure is below 130, but it goes to 150 and above at night. So what the response was to put a night dose here. So we have to make sure that the response to antihypertensive is sustained over 24 hours. And the only way to know that is by ambulatory blood pressure monitor. Also, diagnosing and treating hypertension in pregnancy and diagnosing hypertension, the side effect of medication or any spontaneously happening. Now, additional values of ambulatory blood pressure, you have large number of readings. بعدين يا اخواننا دائما يعني the longer and the more data you have about any particular aspects of this patient, the better. يعني الآن نحن when we do مثلا for example mitral regurgitation أو diastolic function assessment, when we do by echo diastolic function assessment, we assume إنه الآن while we are assessing this diastolic dysfunction, this diastolic dysfunction at this particular moment is representative of his diastolic dysfunction over the entire days before and after, which is not always true. لكن ما بنقدر نعمل ايكو اليوم وبكره وبعد بكره وهكذا. لكن it's not always representative. لكن إذا عندك إمكانية مثلا إنك أنت تطلع من السناب شوتينج أو سناب شوتينج ل a longer period of camera towards particular aspect of this patient clinical picture, it's much better. So having large number of readings is better than single readings at the clinic or somewhere else. So ambulatory blood pressure is more expressive of the actuality of blood pressure. Now it provides average daytime and nighttime reading, and this is more expressive of blood pressure. It also shows us the behavior of blood pressure in daily routine environment. daily routine environment. يعني مرات تلاقي البيشنت at work البلد بريشر حقه 160 170 لما يرجع البيت it goes down ل 120 130 or vice versa. Sometimes the home domestic environment is more hostile than work environment. Nobody knows. لكن دي بتوريك أشياء كثيرة جدا إنه what are other stressors you might need to identify in this patient, okay, and advise to avoid. Now, nocturnal hypertension and dipping pattern, this is also important. I'm going to show it to you shortly. The blood pressure variability over 24 hours and the 24 hours efficacy of antihypertensive obstructive sleep apnea. You can see مع البيشنت بتاع obstructive sleep apnea إنه their blood pressure goes high during their apnea attack. Hypotension, all in all, ambulatory blood pressure monitor is a stronger predictor of cardiovascular mortality and morbidity than single measurement of blood pressure. خلاص يا اخواننا كده؟ Do we agree with that? It is a stronger predictor of cardiovascular morbidity and mortality compared to single measurement for these reasons. Now, how are you going to diagnose hypertension by ambulatory blood pressure? Are you going to use the same targets or you go lower?
Lower.
You go lower. Yes, you go lower. So it is, look here, it is more than 125 over 75, or some other any scientific authorities, they are using more than 130 over 80. But usually, I think I am inclined personally to take more than 125 over 75 as hypertension in the average 24 hour. If it's more than 125 over 75, this is hypertension. Okay. Now, just look here. This one here. The blood pressure is between this and this. Okay. And there is nocturnal dipping. You see the nocturnal dipping nicely here. Compare this one with this. The blood pressure is high. It is high compared to this one here, systolic and diastolic. And the nocturnal dipping is not as deep. Compare this with this one here. Again, high blood pressure and almost no much of dipping. Yani dipping is even more reduced than in here. So this is important. This is the normal pattern with the nocturnal dipping. This is abnormal, high blood pressure with reduced nocturnal dipping, high blood pressure with even worse nocturnal non-dipping. Okay. ولا لاحظوا زي ما قلنا nocturnal nocturnal non-dipping itself is associated with mortality, with or without hypertension. Okay. Now, if you see here, what we usually have is like this. We have a blood pressure at daytime that goes down at night, the dipper, and then there is a morning surge. You know this morning surge? The time when we get most of acute coronary syndrome, this morning surge. This is normal physiological response. But sometimes we have people who have extreme dipper or non-dipper or riser. So we have different pattern of nighttime pattern. It can be extreme dipper, non-dipper, or even risers, each of which has its own association with morbidity and mortality. Okay? So remember how the pattern of blood pressure in the ambulatory blood pressure monitor. So you expect to find dipper and morning surge. These are important. These are physiological responses. Now, left ventricular hypertrophy. Yes? Any question? Left ventricular hypertrophy. طبعا left ventricular hypertrophy can be caused by a legion of condition, pressure overload, volume overload, myocardial infarction, cardiomyopathies, infiltrative diseases, and even physiological adaptation to exercise, athlete heart. So this is left ventricular hypertrophy. So left ventricular hypertrophy is kind of a generic terminology. Now, we have concentric and eccentric. What's the difference between the two? Concentric and eccentric. What's the difference between the two?
The eccentric results from pressure overload.
المشكلة تعرف يا سهير اليوم شو الساوند من عندك فيه مشكلة I think. Your mic is problematic I think. Yes. كده try again.
شكله المايك بتاع رباح.
شكله المايك. Now it's good. Now it's good. So what did you say?
Concentric, there is LVH and a small cavity.
Okay.
And hypertrophied or myocyte.
Okay.
In case of eccentric, there is a stretch of the myocyte and dilatation of the cavity of the LV.
Okay, so you are right. The cavity is narrow here and it's wide in eccentric hypertrophy. Now, if we go histologically and we compare the normal heart here, this is the Sarcomere Histology in the normal heart, which is this one here. Compare it to here with concentric hypertrophy. There is increase in sarcomere, but this sarcomere is laid in parallel. It's laid in parallel. That's why it becomes concentric. While in eccentric hypertrophy, the sarcomere are laid in series. So they lengthen the muscle. Here they thicken the muscle because they are laid in parallel, and here they are laid in series. So you have to remember that histologically, the pattern is different. That's why it becomes concentric and this becomes eccentric. But in terms of the global mass is increased in both, because in both there is increase in sarcomere. Both there is increase in sarcomere. Only the histological arrangement is different between concentric and eccentric. Parallel layout or serial layout. Okay, good. Come on. Now remember, it's not about the determinant of left ventricular hypertrophy, and it's not all hypertensive patients gonna have LVH, because there are some other factors, some of which are genetics. Okay, but we have to remember that any hemodynamic factor is basically the blood pressure, the blood pressure, because we are talking about the blood pressure in particular. And there are some sympathetic nervous system activation, RAS activation, genetic factor, also age and sex and race and obesity and alcohol and other diseases are going to affect. So it's a composite of factors interplaying together, to cause LVH, to initiate LVH, and to decide about how much of LVH is going to be there. Okay, so it's not about hypertension alone, It's a complex process. Now, hypertension leads to left ventricular hypertrophy on one side, and this might lead to diastolic dysfunction. You agree? Now, it can initiate and aggravate atherosclerosis along with other risk factors, and that's gonna lead to myocardial ischemia and systolic dysfunction. So myocardial ischemia, systolic dysfunction on one side, LV hypertrophy and diastolic dysfunction on the other side can lead to myocardial infarction, acute coronary syndrome, arrhythmia and heart failure, and all of that. Okay. Now, left ventricular hypertrophy leads to remodeling at different level, at the level of the cytoskeleton, at the level of gap junction, at the level of ion channels. So these remodelings can lead to arrhythmia. That's why hypertension can lead to LVH, which is arrhythmogenic. LVH of hypertension is arrhythmogenic because it's not about the thick muscle. Deep down in the histology, something is taking place. That's the remodeling of the cytoskeleton, gap junction remodeling, ion channel remodeling. That's why LVH of hypertension can be arrhythmogenic and can lead to sudden cardiac death. Okay. Now, anybody can read this ECG? Anybody?
This is what the ECG sinus
Okay.
of heart rate about 70 something.
Okay.
There is a left axis deviation,
Okay.
and there is incomplete left bundle branch.
Okay.
There is deviation in the lateral lead reflecting LV straining, and there is LVH.
Okay, good. Thank you so much, Dr. Suhair. So we have LVH, that is 1 by voltage criteria. What else do we have, and you have spotted out correctly in this ECG, is the strain pattern and also the incomplete left bundle, or I would call it non-specific IVCD, which is intraventricular conduction delay, because it's broad. So we have voltage criteria, we have a strain pattern, we have a broad complex. Now, when you look at the ECG and you see LVH by voltage, don't stop there. See if there is a strain pattern and if there is broad complex or not. لأنه أي واحد في ديلة it adds to the prognosis. يعني LVH alone without strain, without IVCD has a different prognosis than having strain and IVCD. يعني الآن this is the worst prognosis because LVH, strain and IVCD. Okay? لأنه it indicates that it indicates إنه ربما and this is my speculation لأنه ال LVH is not about muscle, it's about muscle leading to changes and remodeling, ischemic remodeling, channelopathies, interstitial expansion, fibrosis. That's why بيحصل مشكلة electrical conduction and electrical changes ويحصل لك strain pattern and IVCD. يبقى strain pattern and IVCD adds to the prognosis of left ventricular hypertrophy by voltage. Okay, so you get this point, and we said that the strain pattern is basically this one: ST segment depression and asymmetrical T wave inversion. It is asymmetrical, meaning يعني بتكون شكلها عاملة كده. While the ST segment, the T wave inversion of ischemia mostly is symmetrical. And if you divide it into two, they are two symmetrical halves, unlike this one here. Okay, so this is T wave inversion of strain. Now, if you look here, this is the normal LVH, the normal muscle, and this is left ventricular hypertrophy. Look at the histology, how different it is. Now, cells were packed up together tightly, started to be separated here in the LVH. Now the myofibril is stouter, the muscle is more pronounced. This is concentric hypertrophy and this is eccentric hypertrophy. In terms of mass, both have large mass, but histologically they are different and etiologically they are different. because here is usually volume overload, here is mostly pressure overload. Like we said, the histology here is sarcomere increase and lay it down in parallel, and here it is laid down in serial manner. Okay, now also if you look here at this normal histology and abnormal histology, look at the histology here, which is fibrosis. That's our problem. So there is increase in fibrosis. Okay, so it's not about the muscle increase. No, inside histology there are different changes, remodeling and fibrosis and channelopathies and cytoskeleton changes and okay, that's why left ventricular hypertrophy is serious condition associated with high mortality because of what's going on inside the histology. And remind you, not all LVH is alike, though it might look alike muscularly by echo, but when they do histopathology analysis, it's different by the amount of fibrosis, architectural changes, and stuff like that. That's why some people advocate the use of cardiac MRI to see how much fibrosis in each left ventricular hypertrophy to define the prognostication of each left ventricular hypertrophy. Yani the more fibrosis by cardiac MRI, the more prognostic. The LVH. Okay. Now, heart failure, we have and we still have, we used to and still the definition into 3 categories, right? Reduced ejection fraction and MR ejection fraction. What's MR ejection fraction? MR ejection fraction is that ايوه في الاول كان بنقول mid range. Now they call it mildly reduced, not mid range, mildly reduced. And HFpEF, which is preserved ejection fraction. Sooner or later, probably they are gonna add heart failure with supranormal ejection fraction. Heart failure with supranormal ejection fraction. ليه؟ why the fuss؟ ما خلاص يعني نحن عندنا heart failure with ejection fraction more than 50 يكفي يعني. لكن أنهم وجدوا إنه ejection fraction عنده U-shape pattern، بمعنى إذا أنت حسبت ejection fraction on one side والmortality on the other side هتلاقي الموضوع ماشي كده. يعني كل ما ejection fraction it drops كل ما المورتاليتي زادت. When the ejection fraction start to rise, المورتاليتي برضه it increases. يعني above 65, the mortality increases. Patients who have heart failure with ejection fraction more than 65 have actually higher mortality than patient of 50 and 60% ejection fraction. Okay. So remember this entity, supranormal heart failure with supranormal ejection fraction. Now the grades of systolic dysfunction is grade 1, 2, and 3, and we use the mitral inflow signal along with the mitral annular velocities, but we will have a dedicated lecture for the systolic function evaluation by echo. So don't mind this slide. Now, this is heart failure with preserved ejection fraction and how the different risk factors can ally together to produce this syndrome of heart failure with preserved ejection fraction. Okay, I might give you a separate presentation about heart failure with preserved ejection fraction, but because there is some few updates, but they are very crucial new updates in HFpEF. Basically, it's about phenotyping and phenomapping of HFpEF. So they no longer look at HFpEF as a single disease entity, but they are in attempting to divide it into different phenotypes. and they think that failure of all clinical trials directed towards management of HFpEF failed to elicit hard clinical outcome because the HFpEF is heterogeneous. We are having a heavy cargo, you know, so they need to unfold HFpEF into separate entities, you know, and see how things are going to change. So this is the future of HFpEF. Now, hypertension can lead to atrial fibrillation? Yes, of course, because hypertension leads to left ventricular hypertrophy, leads to LV systolic and diastolic dysfunction, and this is going to elevate the left atrial pressure and going to dilate the left atrium. Once the LA pressure increases and it becomes dilated, this is substrate for atrial fibrillation formation. Other side, hypertension increases the activity of RAS system, and this also leads to atrial hypertrophy and fibrosis. So hypertension is important underpinning of atrial fibrillation. Now, remember the treatment of heart failure with preserved ejection fraction? Yeah? Can you summarize it to me? How are you going to treat patient with HFpEF? HFpEF. HFpEF.
Treat the underlying cause.
The underlying cause. Tani?
And symptomatic treatment.
Diuretics.
Diuretics.
Good. So thank you, Dr. Kheirallah. And you mentioned the only two class 1 indication in HFpEF management. Only two. اللي هما the treatment of comorbidities, بالذات hypertension. You look here, this one with the arrow. It's the only class 1 indication in green. All the rest are class 2A and B. يعني class 1 indication هما honestly speaking are two. Treatment of comorbidities and giving diuretics for congestion. Now, giving SGLT2 inhibitor, MRA, ARNI, or ARPs, these are all class 2. SGLT2 inhibitor is class 2A. MRA is class 2B. ARNI is class 2B. وبالذات في شنو؟ بالذات, look here, particularly patient at the lower end of the spectrum, ejection fraction lower end of the spectrum. What's the meaning of lower end of the spectrum of ejection fraction? يعني بين 50 and 57. بيستفيدوا من MRA, بيستفيدوا من الارني، لكن لما يكونوا اكثر من كده ما بيستفيدوا كثير. وفي studies like TUPAC study وفي باراغوني study بتاعت الارني. غالبا البنفيت حصل عند البيشنت اللي عندهم اول شيء الفيميل استفادوا اكثر، والحاجه الثانيه انه البيشنت الايجكشن فراكشن حق ما هو الهيف بيف معناته شنو؟ اي ايجكشن فراكشن مور ذان 50. الناس اللي بين 50 and 57 استفادوا اكثر من 57 and above. عشان كده هنا لاحظ في كومنت انه to use it on the lower end of the spectrum of ejection fraction. The lower end of the spectrum of ejection fraction. لكن ال SGLT2 inhibitor, no such comment. You can use it for all. And it is class 2A. It's more powerful than MRA and ARNI. لكن the only class 1 is the treatment of hypertension and comorbidities. Okay? Now, hypertension leads to left ventricular hypertrophy and dilatation. And look here, this slide expresses it so clearly. You see the blood pressure as the blood pressure increases, the atrial enlargement increases in men and in women. And we said, أول ما left atrium become dilated, بيحصل فيه remodeling, fibrosis, substrate for atrial fibrillation. لكن هل ال left atrium enlargement لوحده كده is prognostic؟ بس adjusting for all the other confounding factor. هل ال left atrium إذا قارنت patient with normal left atrium type, mild or severe dilatation, and you adjust for all the rest of confounders, will the left atrial size be prognostic? Yes. And here is the study which has shown that left atrial volume index, معناته left atrial volume divided by body surface area. Normal is here and severely dilated is here. See, the survival estimates are here. And this is mild and this is moderate. So there is a great association between the left atrial volume index and survival, regardless of the etiology of left atrial dilatation. This is an important piece of information. Left atrium is prognostic, Okay. Now, have you ever heard about atrial functional mitral regurgitation?
Yes,
What is that?
it is mitral regurgitation result from annual dilatation due to dilated left atrium.
Very good, very good. تمام. يبقى معناتها الآن الفانكشنال MR بقى فيه two components: ventricular functional MR and atrial functional MR. سابقا بس كنا بنعرف ventricular functional MR، حتى ventricular ما بنقوله لأنه لما نقول functional MR it is خلاص معروفة لدينا by convention إنه it is LV dysfunction leading to mitral regurgitation. لكن الآن we have to distinguish إنه ممكن يكون atrial functional. يعني ال MR ممكن يكون due to the dilatation and impairment of the LV, or due to the dilatation and remodeling of the left atrium, affecting the annulus, pulling the leaflet apart and leading to atrial functional mitral regurgitation. And this is hypertension. We said that hypertension leads to atrial fibrillation, leads to atrial dilatation, and can lead to functional MR due to the remodeling it creates on the left atrium. عشان كده غالبية البيشنت اللي قاعد يحصل atrial functional MR عندهم بنلاقيهم patient who are hypertensive, atrial fibrillation, diastolic dysfunction, left atrium بيكون كبير, الانيولس dilated وكده. اوكي. بعدين الهايبرتنشن كان also زي ما ذكرنا aggravate pre-existing disease لأنه الresistance للoutflow is high, فالpressure will be high on this side. And that's why after TAVI, patient with severe MR goes down to mild and moderate. لأنك أنت you remove the afterload, and hypertension is an afterload. So hypertension increases pre-existing disease, pre-existing MR, or can create new MR because of atrial functional MR because of what it does on the left atrium, Okay, good. Now, can kid when you study the ECG, don't look only at the LVH and the strain and the interventricular conduction delay. برضو عاين ليه البي mitral, bifid, B wave in lead 2, and the negative polarity in V1. Okay, now this is important. Left atrial enlargement in ECG. Now, hypertension, we know that ischemia is a mismatch between demand and supply. So you either have decreased supply and or increased demand. Hypertension does both. An increase afterload, increase LVH, increases demand. وعندك enhanced atherosclerosis that is going to decrease supply. So hypertension is important risk factor for ischemic heart disease and acute coronary syndrome. ومشكلته الثانية إنه الhypertensive patient إذا عندهم coronary artery disease compared to non-hypertensive patient with the same severity and same extent of coronary artery disease, the hazard ratio of MACE is higher in hypertensive patients. يعني look here, we have obstructive coronary artery disease. These are the hypertensive patients, these are the non-hypertensive patients with the same coronary artery disease severity, but the hazard ratio for MACE is higher in hypertensive group. So hypertension is important add-on the mortality. Now, hypertension and aortic stenosis. قلنا الاورتيك stenosis is after load problem. طيب لو الافتر لود بروبلم بتاعت الاورتيك ستينوسيس جاء عليها افتر لود بيردن جديد ثاني هو الهايبرتنشن، ده حيكون دبل وامي اون ذا هارت. اتس دبل وامي، مصيبتين على على الليفت فنتريكل، ولذلك الليفت فنتريكل is likely to grow stouter and thicker لما يكون في hypertension with aortic stenosis than when there is no hypertension. وحتى الدروب in ejection fraction is more likely مع aortic stenosis if it's accompanied by hypertension. Okay? والمشكلة الثانية, look here, hypertension with aortic stenosis. Time to ischemic cardiovascular event increases in hypertensive patients compared to normotensive patients. Time to cardiovascular death increases in hypertensive patients compared to non-normal or normal blood pressure patients. Time to death from any cause with aortic stenosis is more in hypertensive than normotensive patients. So hypertension makes the picture really gloomy with aortic stenosis. Just having hypertension along with aortic stenosis adds a lot to the prognosis. Now, hypertension and mitral regurgitation, look at this amazing, amazing slide. The higher the blood pressure across different ranges of age, as the blood pressure increases, the hazard ratio of MR increases. See? So this is MR and hypertension as causal link between hypertension and mitral regurgitation. Okay. Now, hypertension and aortic root. You think that hypertension is affecting the aortic root? Hmm?
Yes.
In what way?
Cause increase the wall stress and cause the irritation of the aortic root.
Okay.
Also by increasing the afterload, it causes dilatation of the aortic root.
Very good, very good. وبالذات عند البيشن اللي بيكون عندهم pre-existing aortopathy. اللي عندهم pre-existing aortopathy, having hypertension on board is going to aggravate the progression of aortopathy, and they are more likely to have dilatation, aneurysmal dilatation, faster and earlier than their counterparts اللي ما عندهم hypertension. ولذلك you have to treat hypertension even more aggressively if there is aortopathy. Hypertension not only affecting the dilatation but can induce dissection in aortopathy patient. صح؟ It's important. الحاجة الثانية برضو أنه hypertension increases the trauma on the blood vessel. I have to mute. Okay. Because hypertension increases the trauma on the vessel, هيحصل aortic root stiffness. Well, aortic root stiffness is associated with the functionality of the aortic valve. يا اخواننا لازم تعرفوا انه الاورتيك valve is not about the leaflet. الاورتيك valve عنده close collaboration in term of function بينه وبين الروت. اللي بيحصل في الروت بيتاثر به الفالف، واللي بيحصل في الفالف بيأثر في الروت. اوكي؟ تمام؟ فبالتالي اذا حاصل stiffness الفانكشنز بتاعت الفالف كاسب بتتاثر، ولذلك في patients كثيرين انتوا قد تكونوا شايفينهم عندهم AR mild, moderate, sometimes even more than that, والleaflet are normal looking, لكن only it's about the root which is stiff or something like that. So if you cannot elicit the etiology of MR being degenerative, rheumatic or stuff like that, think of انه ربما السبب ممكن يكون في الروت. ونوت necessarily dilatation في الروت، حتى stiffening في الروت. لو حصل وstiffening ده طبعا you can't know by echo, probably high pulse pressure might tell you انه في stiff root ممكن, لكن otherwise it's difficult to gauge in. ف this is important. فأهم شيء غايته عايزكم تتذكروا إنه الروت والfunctionality of the aortic valve are intercorrelated. Okay. Now آخر slide أو ربما the one before, لا, systemic hypertension, pulmonary hypertension, are they related? Can hypertension lead to pulmonary hypertension? Yes. How? لأنه قلنا إنه الhypertension can lead to diastolic dysfunction, can lead to heart failure with preserved ejection fraction, can lead to left atrial remodeling, can lead to atrial MR. All of these conditions can elevate the pulmonary artery systolic pressure. يبقى systemic hypertension can lead to pulmonary hypertension indirectly. Okay. في cases مرت علينا, one of which is depicted in this echo, not necessarily this, لكن it looks like this one. أنا قبل كده جاني patient, I have seen a couple of patients like this. High blood pressure, so I was above 170, and treated hypertension for some time. Well, he denied being hypertensive, he denied. فجاء ب severe LV dysfunction, an MR, functional MR, stuff like that. We treated him initially by antihypertensive, intravenous antihypertensive, and then by oral. And after a week or two, his ejection fraction comes back to normal. So this is hypertensive cardiomyopathy, can be acute hypertensive cardiomyopathy. So يعني part من الhypertensive emergencies اللي انت you could encounter انه البيشنت ممكن يكون عنده hypertensive cardiomyopathy, severe LV systolic dysfunction relating to high blood pressure. And when you control the blood pressure, LV might recover, the LV might recover either partially or completely. Okay. طبعا of course after excluding ischemia irrelevant patients. لكن what I want you to remember is إنه high blood pressure can occasionally lead to severe acute LV systolic dysfunction. Okay. Thank you so much.